between those two is the medication that you use for the different stroke etiologies. So if the stroke is due to cardioembolism or hypercoagulable state, you put them on an anticoagulant. For the rest, basically it's just antiplatelets and statin therapy. That's really dumbing it down, but that's basically what the management is for secondary stroke prevention. I believe this is my last slide. Again, thank you very much for inviting me. I'll be great to answer your questions.
Thank you, Archie. Here you go. We'll take a few questions. Okay?
Yes.
You got time.
Yes, we have time. We have time.
Actually, I have two questions, but I ask one first. What is endovascular therapy?
So endovascular therapy or endovascular intervention is going intra-arterial intervention, basically. You go through the groin and go up there and stent it, or balloon angioplasty. So something like what, if you're familiar with the catheterization of the heart, it's the same thing. You go up into the head and do the same thing. You stent the MCA, or you barely stent the MCA. You angioplasty it if you need it, or you stent the carotids if you need it. So that's the endovascular therapy.
You do this procedure or IR?
So the question is whether I do the procedure myself or not. Sadly, I don't. We have a neurosurgeon who does that, but there are trained neurologists who could do that too. If I did 2 more years of training, I could do that, but I did not. So.
You're IR with that, interventional radiology.
Yes, so interventional radiologists can do this. Neurosurgery, neurosurgeons who did training on this can do it, and neurologists who did training on this can do these things. Yes.
You just mentioned that PFO, if you know stroke, you don't do anything about it. What about the risk of a PFO for stroke on the
you mentioned about the PFO, if no stroke, no other symptoms, you don't do any procedure to close it. And I just want to know what is the risk factor on the ratio about the PFO can cause the synthetic problem.
Yeah, sadly, I don't have the number inside my head in terms of the percentage risk of stroke in people with PFO, but I remember reading an article from the Neurology Journal, I think a year ago now, that says when people get a cryptogenic stroke and the only risk factor they have is a PFO, even in younger patients, it almost never recurs. But I don't have the exact number, sadly. Sorry.
Yeah, thank you, Archie, for your outstanding outlining for stroke prevention and treatment. One question now, as a cardiologist, we're asked more and more to put even recorder. Now, can you give us some comment and what is the indication, and currently is what indication in class 1, 1A, B, C, please?
Okay, so currently we do, I think, so the question is when do you put an implantable loop recorder or put just cardiac monitoring in general. So we suggest that in patients who have cryptogenic strokes. So cryptogenic strokes mean strokes that we think are cardioembolic, it's just that we haven't detected it yet. So that's the exact definition of cryptogenic. So we suggest, at least in our practice, we use the Zio patch first, which is not invasive. You can put it for 2 weeks. If the suspicion is still high, and for me, I look at the echo. If the left atrium is enlarged, I do suggest doing an implantable loop recorder. Now, in terms of the level of recommendation for that, I don't know. I don't know. I don't have it. I don't have that data.
Very good talk, Archie. Two questions. Number one is the sleep apnea. You said 70% of the stroke patients develop sleep apnea, or it's the other way around. People have sleep apnea in the first place, probably was not aware of until stroke happened and you study it, then it's present. So do we know the cause or the relationship? Number two is about anticoagulation. Lovenox, like low molecular weight heparin, is that as good as warfarin for atrial fibrillation, anticoagulation, or is not studied, or is as good as oral anticoagulation? So if you can comment on that. Because we don't really use warfarin anymore for DVT, for my practice as a neuro-oncologist. Because as you know, the warfarin is so tedious, and also now the low molecular weight heparin is not that expensive anymore, and then it's very safe. Once you give it, you know it's given, but the warfarin can be up and down, drive everybody crazy, and also the risk for patients is very high, because if you cannot check or they change their diet, that warfarin can, their RNR can be really 3, 6, 7, and then you have a bleed, and then, so that's to me is risk, and then also the cost is really not overwhelming as it used to be.
Okay, so to answer the first question, the thing that I mentioned, 70% of stroke patients develop it. Yeah, you can contest that maybe it was undetected because most people don't really look for sleep apnea. The only time they think about it is if they're sleepy all day or somebody complains that they snore all night, their partner's complain. So you have a point. It could be that it was there before and then in fact, it's a risk factor. But the reason why it's also common after a stroke is because most of the time the swallowing and the nasopharyngeal muscles get affected after a stroke, and that's why the incidence of obstructive sleep apnea after a stroke is high. So that's the reasoning behind that. Now, for the blood thinner Lovenox, yes, we actually suggest using Lovenox for patients who need anticoagulation because their strokes are from malignancy or paraneoplasm or any hypercoagulable state or prothrombotic state because of a malignancy. And I guess most of your patients are skewed towards that. You're an oncologist. So yes, for people who have strokes, and the only risk factor that we find is cancer, the best anticoagulant is actually Lovenox and not warfarin. Yeah, so I think that answers your question.
I have a question about the dietary recommendation of the red meat. I don't think there's very strong evidence so far that red meat can raise risk for stroke. And I think from my understanding as the homocysteine, the methionine content is higher in red meat. So what's the other difference between red meat and white meat? And we keep telling people to eat low carb diet, and then you cut the meat. And what can people eat other than chicken and fish? What if the patient like the chicken or fish? What can you do?
Right. I actually get a lot of that complaint from my patients. They said, they don't like fish, so what are they going to eat? Just chicken all the time, and chicken breast at that, because chicken wings and chicken legs and thighs is actually red meat. Maybe they can eat turkey, yeah. I guess I don't really have a good answer as to the red meat issue there, but that is what's recommended by the American Heart Association. They suggest
Several years later, they were changed.
I bet, just like eggs, right? The amount of eggs that we need to eat every day. But right now, as of the guidelines that we follow, that is what we suggest. It's not that they can't eat it. Let's just put it this way. That's what I tell my patients. You can have holidays or special occasions for birthday. Sure, go ahead, eat at Martin's, but most of the time, or at least you should control what you eat fish, eat white meat. So yeah, that's what I tell my patients.
Fish has a lead and mercury.
That's true. So I guess keep your poison, but at least you won't die from a stroke.
One more. For carotid artery thrombosis, do you suggest any surgical intervention?
Yes. So for carotid stenosis, as long as it's symptomatic.
Not stenosis, thrombosis.
Thrombosis. In the acute setting, actually, even if it's not acute, if you see a thrombus sitting in the carotid, yes, I send them to my neurosurgeon interventionalist. That way, because if it's flapping around, that clot is flapping around in the neck, that's like a ticking time bomb. So yeah, do surgery for that.
Thank you, Archie. Okay. Last one. Okay.
My question is, I remember in the old guidelines when you have more than 70% of stenosis, we should refer to the surgery to do the CA. Is it still the current guideline now?
Yes, it's still the current guideline, but I emphasize the symptomatic part of it. A lot of my colleagues, the vascular surgeons, send their patients to me when they find asymptomatic, meaning it's just stenos, but the patient has never had a stroke. They get my opinion whether to do surgery or not. And the only time I do surgery is, in her example, if there's a thrombus there that's flapping around, if the plaque is unstable, that's the only time we suggest doing that. Or if they've had, so you keep asking them for TIA symptoms because they might not be aware that they've had anything. So these are the things that you ask for, and if they've had that, then yes, by all means fix it. But if truly they didn't have any symptoms and the plaque is stable, it's calcified, most of the time we don't touch that.
Sorry, I have a question. Actually, two.
Sure.
The first one is you mentioned about the treatment anticoagulation. If there's a large area of stroke, you said it's contraindicated. Do you have any criteria? What's the size? That's my first question. The second one is blood pressure control. Somebody had a stroke, like acute stage. Typically, we don't lower the blood pressure too much. Do you have any guidelines about how low we can go?
Right. So for the anticoagulation in large strokes, it's not that it's contraindicated. You just need to be careful. We still put them on a blood thinner, especially if we do an echo and there's still a clot in the left atrium. Even if it's big, we put them on it. You just have to explain to the patients and their family the risk and the benefit. And so, when do we start it? It's subjective. Depends on the neurologist how gutsy they are or how ballsy they are. If they're a little bit more on the conservative side, they can wait, like I said, up to 2 weeks. I have colleagues who do that, but most of the time for me, I wait around 2 days. If the patient is stable and it's not getting worse, you can start them on that. And how big? Usually if it's large vessel occlusion, that's big, meaning if the MCA is completely occluded, or a third of the hemisphere, that's what we consider big. And for your second question, blood pressure after an acute stroke, yes, we suggest permissive hypertension after acute stroke, and that's up to 48 hours. That's the guideline, up to 48 hours. But again, these are guidelines. Okay, you can always change it a little bit. Guidelines are not rules or laws that you cannot break. So even laws sometimes you break, right? So yeah, 48 hours is what the guideline says, but we have patients sometimes who we start controlling the blood pressure after 48 hours and they start to deteriorate, so we liberate the blood pressure again after that, if that's the situation.
All right, one more question, the last one.
You mentioned about the medication treatment such as Rafina, Coumadin, DOAC, stantin treatment, and antihypertensive drug, and the carotid endarterectomy for the treatment of stroke. How about the therapy? Do you recommend any therapy such as speech therapy and occupational therapy, PT, and how long they should be on these kind of therapies?
So, yeah, the reason why I didn't mention those is the talk was for primary and secondary stroke prevention, but definitely after a stroke, no doubt. In any stroke center, they should see the rehab physicians, the PT, the OT, and the speech therapists. No doubt, they need to see these specialties. How long and when? We usually wait, again, around a day or two until we call the rehab doctors, depending again on how severe the patient's condition is. Obviously, if the patient is bedridden and severely affected by the stroke, there's really no point getting the therapist there right away. Maybe the speech therapist, just so they can evaluate the swallowing as soon as possible. But for patients who are less debilitated, yeah, as soon as 24 hours we get the therapists to see them. How long should it last? Usually the best time for recovery after a stroke is the first 6 months. So I tell my patients, therapy right away, as much as you can, first 6 months to a year. I sometimes extend it to a year, just so they would still be encouraged to do their therapies. And again, when I say therapies, obviously physical, PT, OT, and speech will not go on for a year. They should, when I say therapies, that means they should continue doing their home exercises and all that once they graduate from their formal rehab.